New Jersey Center for Tourette Syndrome and Associated Disorders, NJCTS, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Kelly, thank you, and good evening, everyone. Before I introduce tonight's presenter, I would like to call your attention to the slide on your screen. On Saturday, November 14th, we are holding our 6th annual New Jersey Walks for TS event in Mendham, New Jersey. Registration will begin at 8 a.m. If it's not possible for you to join us that day, I hope you'll visit our website and make a donation in support of our educational outreach program, which supports and delivers school-in services, among other programs, for kids and families living with TS. Now to the introduction of tonight's presenter, Dr. Lawrence Brown. Dr. Brown's presentation tonight is the second of a two-part webinar series on medical transition. Part 1 was done on April 22nd of this year and is available for download on our website. Dr. Brown is Associate Professor of Neurology and Pediatrics at the Children's Hospital of Philadelphia and the University of Pennsylvania School of Medicine. He is Director of the Pediatric Neuropsychiatry Program, a multidisciplinary clinic for children whose complex learning and behavioral issues have a neurobiological base. This population includes Tourette syndrome, high-functioning autism, and complex ADHD with comorbidities, as well as epilepsy, genetic syndromes, and other neurological disorders. Additionally, he is a senior clinician in CHOP's Pediatric Regional Epilepsy Program, where he is principal investigator on numerous clinical drug trials in pediatric epilepsy. Dr. Brown, welcome back. And now, without further introduction, I'm pleased to turn tonight's program over to you.
Thank you, Marty. It's a pleasure to be back. And for those of you who have already seen the first part of this, where I tried to go over some real basics in Tourette syndrome, and as well as the introduction to transition, today I really want to focus even more on the concept of transition and the work that I've been doing both locally and nationally, and how it can be applied to Tourette syndrome and other conditions that are so often associated with it. And finally, I really want to invite parents and caregivers as partners in this process, because we have not done a very good job as medical professionals in the past, and we are still working out the details on how to do it well. So just to remind everybody, Tourette syndrome is defined by the motor and the verbal tics. And as this cartoon shows, the motor and the verbal tics tend to start between 5 and 8 years of age. But many children also have other significant conditions, such as ADHD, which occurs in at least 60% of children with Tourette. And as you can see, that tends to start earlier. One of the implications there is that the treatment of ADD is sometimes accused of causing the Tourette syndrome, which it doesn't. But it is true that stimulants can exacerbate tics in the minority of patients. The other condition that's so often associated in approximately 20 to 30% is obsessive compulsive disorder, But if one looks at obsessive-compulsive symptoms, it's even more frequent, sometimes up to 50%. And what this shows is that it's very common in the preschool population to have kids love to hear the same book over and over and over, or that they have to do things just so. But that is age appropriate, and the OCD that comes with Tourette syndrome when it occurs is often in the beginning of the second decade. But ADHD and OCD are not the only conditions that are associated with Tourette syndrome. Anxiety disorders occur in 20 to 30%. Intellectual disabilities and learning challenges in about 20%. Just under 5% in a large series have autism, even though children with autism have symptoms that can be called Tourette syndrome in approximately 20%. And lastly, in case you didn't know it in your own kids or the ones that you know with Tourette syndrome, at some point mood and rage can occur in basically everyone, typically in the pubertal teenage years. So though we're talking about Tourette, and on paper that's the tics, we cannot forget the other conditions. And why is that? Because as I said, tics define the disorder, but in fact the comorbidities are often more disabling in some children and often last longer, have a life of their own. And in fact, if I go back, you can see that in the teenage years, the tics are starting to go away in blue, but the ADHD and the OCD tend to linger. Whoops. So, in fact, in a large study, which I mentioned back in the spring, in over 3,000 patients in an international Tourette consortium, only 1 out of 8 had only tics, and the vast majority had other comorbidities. So when I talk about outgrowing Tourette's or outgrowing the neurologist, we don't always outgrow all the symptoms. And I guess I forgot to point out this slide, which shows it better, that the tics may get better while the others don't. And that's all I'm going to say right now, unless there are questions about the natural history of Tourette. I'd like to talk more about transition and then come around and how the circumstances of neuropsychiatric disorders can play out. Many people think of transition as a moment in time. That is not true. That is the transfer. That's the last step in the process, which takes years. And we like to say that transition is preparing children with chronic illness and disease and their families how to become the most effective, mature, and self-managing adults. What are the goals of transition? This is what I put down as what most neurologists would say. It's to prepare young adults so that they can take responsibility for their chronic disorder, so that they can achieve maximal independence in activities of daily life, achieve the best education, the best jobs, and the best social relationships. And in terms of medical transition, it's to transfer to adult providers and make sure that they have ancillary supportive services. The parent, and I'm talking, I believe, mostly to parents and caregivers, may have a slightly different version. They want a young adult who can make decisions on their own and advocate for their needs, a mature person who has a positive outlook on life and is looking ahead to the future, somebody who can work, learn, make friends, and be independent, and where appropriate, whether for physical or intellectual or other needs, have the right supports, the right accommodations. And I think that most parents would agree that they would like to move ahead and pass decision making for their young adult to that young adult. As hard as it may seem, they need to be ready to take care of themselves. And this process takes planning, and if all this sounds strange, it's because there have been very few guidelines for success that doctors of all stripes have tried to come up with. Which brings us to the basis of the work that I'm doing and other people like me. And it goes back to something that I was not personally involved with but was excited to read in 2011 when the Academy of Pediatrics, Family Physicians, and the American College of Physicians, which represents over 150,000 internists and specialists in adult medicine, got together and tried to come up with the core elements of transition planning. And these are the 6 that they came up with. That, number 1, there has to be a policy. We need to track it and monitor it over time. We have to do what it takes to get the adolescents and young adults ready to take self-management. We need to plan for them. And obviously, at some point, we need to transfer care. And then we have to ensure that all the work that we've done actually happens and is completed. This may come as a shock to some of the people listening, but it doesn't start at 18, and it doesn't start even when they enter high school. It starts as early as age 12. And there's actually evidence why that should be, and it's based on the fact that intellectually, children by the age of 12 are ready to make some significant personal decisions about their lives. In fact, whenever we do studies now, by that point, we have to make sure that we get the child's assent because they need to be part of their own medical issues. And so we don't transition at age 12, but we have to make sure that that people are aware that there is a policy, assuming there is one. And by 14, we want to start making sure that those plans are in effect. And that actually is in perfect synchrony with the school-based programs. I don't know how many people listening have children who have individualized educational plans, But if you do, the educational transition planning has to be done, initiated by this point. Whether or not we've actually spoken about it, by age 16, we ought to be getting ready for an adult model of care and to discuss transfer. What is an adult model of care? Pediatrics is family-based. Adult, and I'm talking to adults, I assume, all know that it's all about the patient, even more than their immediate environment. When should transition take place? There is no one moment which is ideal. There are moments in some institutions where the door closes and people are forced. That makes it easier on the doctors. I'm not sure it makes it easier on the patients and families. But by 18, we really ought to be starting to think about whether or not the youth is best served in a pediatric or an adult model. And at some point, they grow up, and at some point, the care is transferred, hopefully to another medical home. And by that, I mean typically primary care, where all of their needs are either met or coordinated with or without specialists. And this all can be seen, and at the very end, I'll give you the website again, but this has all been organized in an absolutely beautiful fashion by a federally sponsored agency called gottransition.org, and they have wonderful resources for parents, for kids, for doctors. And that gets me to the project that I've been working on, and in fact am the lead author of a large group that I put together to try to make sense of neurologic transition. Those of you who were on this call before will remember how I said that neurologists were behind the curve, probably because we deal with such a wide variety of disorders, ranging from early childhood cancer to headache to muscular dystrophy to cerebral palsy and epilepsy and autism. So unlike a disease-based model, that one size does not fit all, and in neurology, unfortunately, we do have many kids who have intellectual disability and therefore may not be fully independent as adults, which is not the case in most neuropsychiatric disorder, but the neurologists have not been leading the pack in trying to figure it out for all kids. And I decided that we would do best to try to make sense of this. And interestingly, neurology is the first specialty that has taken the charge to try to do just that and to figure out what are the core principles of good transition. So the goal of my project was to help kids avoid falling off the cliff when they turned 21, when they graduated college or they finished special ed, when services changed completely and the model of care changed and the parents were getting older, and the resources were fewer. And I wanted, and my colleagues wanted to outline, as I say here, the responsibilities, describe the challenges, and most importantly, provide mechanisms to help us to plan and coordinate this process. What did I do? I brought together an interdisciplinary team and tried to think about all the different people who might have complementary ideas. Where possible, we tried to find what was said in the literature where it didn't exist. We tried to come up with an expert opinion, consensus, and then we developed the principles and had 5 different vignettes outlining how does this work and how are these principles possible to be throughout all of the problems of child neurology, one of which was not Tourette syndrome, but the neuropsychiatric disorder was ADHD, which was actually a quite good substitute, but I will use Tourette syndrome specifically as we speak later. We sent it out for peer review, and the guideline is ready for publication, hopefully very shortly. So who did we bring together? We brought child neurologists, nurses, adult neurologists, pediatricians, the specialty called MedPeds that focuses on young adults. We had social workers, a social worker and an occupational therapist. We had an adult former patient who started her career in epilepsy at age 3 and now runs her own nonprofit, and a family member who grew up with a brother with very severe epilepsy who started the Lennox-Gastaut Syndrome Foundation to represent living with family members. The work that we did was sent out to the Child Neurology Society, CNS, to the American Academy of Neurology, the American Academy of Pediatrics, and we've already had endorsement by the child and adult neurologists, by the neurology and special needs sections of the Academy of Pediatrics, and it's waiting at the executive committee for endorsement. It was also sent to child psychiatrists and many other, up to 15 organizations that have approved and given us the go-ahead that they agree. And now I just want to talk about the 8 core principles that we came up with before I tried to apply it to Tourette. The first thing is, as I said from the outset, that there should be a transition policy. One would think that's true, but I have a feeling that if I queried the entire group, very few people would say that their providers have a written policy that they can see when they walk into the office. I think it's really important that parents and the young emerging teenager realize that they're not going to be in pediatric care forever, and that the wonderful paternalistic approach that pediatric generalists and specialists have is not always encouraging their maximal independence, and we need to do everything it takes to move to the fully successful adult life. And specifically in the medical model, we need to remind them of that difference, which I've already mentioned, from family to individual, and encouraging the teenager and young adult to be the primary decision maker, or at least an active participant, and not just watching a discussion between parent and doctor. The second principle that we came up with is that we can't assume that the kids are doing all their jobs to become independent, but that we have to assess it, and we need to continue to assess it so that we watch them grow and make sure that it's documented. The electronic medical record, with all the burdens it gives us the benefit of easy way to follow things. And in this manner, we do have some validated system, and I'm happy to say at the Children's Hospital we have this in our medical record and can look at it and watch it improve. It's everything from knowing what the name of your disease and what medicines you're on, and whether or not you're responsible for taking the medicine, and how you'd fill an appointment, etc. These are not things that we expect a 12-year-old to do necessarily, but these are aspirational and should be accomplished at some point during their growing up. The third principle was that we would, at some point, phase in discussion of the medical aspects so that the youth is fully aware of their condition, that they understand what they should do if there were problems, more and more that they understand the genetic implications of their disorder. And as uncomfortable as it may be at times, we need to address issues that are important to them, their individuation as sexual beings and emotional beings, the safety or the dangers of driving, drugs, alcohol, and general wellness. If you're not talking about these all in any one visit, that's probably totally expected, because we're all busy and we all have limited time, but little by little, these things need to be covered at an age-appropriate time. Whoops, I just screwed up. Let me get there. So, how can a physician, a neurologist, handle this? The ideal setting even is not entirely clear. It would be wonderful to have an annual visit dedicated to this, but we have many people who really belong at their jobs. The kids belong at their school, and the doctors are overwhelmed with the need to see sick patients. So at the very least, we recommended that it be incorporated not into an acute visit when things are falling apart, but into a well visit. And that means, and I hope you're listening, if a child is doing well, even if he's not on medicine, there is still a reason to have a relationship with your doctor and to see them from time to time. As I said, it's unrealistic to cover everything every time, but obviously when a kid's turning 15 or 16, they expect most of them to drive, and we need to talk about how the Tourette syndrome, the associated ADHD, the medications they're on may have an impact, and both for the good and the bad. And lastly, we need to recognize that as kids grow up, as the tics go away, as they may not be any longer on medication, we are still responsible as specialists, even if we haven't seen them. We're not happy about it, but if there's a problem, we need to be responsible at least until the transfer is completed. One of the things that we came up with, and you might talk to your doctors about, is having a piece of paper or even a flash drive that has a summary, so that were there to be a problem and you had to go to an emergency room or you're moving to a new city, to have the information available, so the emergency room or new specialist doesn't start from scratch. The fourth principle is that we need to at least expect whether or not a young teenager is ever going to be fully independent. I think it's extremely unlikely that this will be important for your kids who do not have physical or intellectual disabilities, but these are general points, and for some people they may be important. I have to be careful I don't, yes. By age 14, as the school is getting their transition plan in place, but also with the input from parents, other health providers, legal, occupational therapists, physical therapists, speech therapists, psychologists, and especially the kid, we want to be sure that we're meeting the comprehensive needs. And there should be a plan in place that is addressing all of this, but focused on the medical aspects. So in terms of Tourette syndrome, I think most people listening know that tics tend to go away, at least in 2/3 of the cases. Those that persist, the vast majority, are much better. But if there has been associated ADHD, OCD, anxiety disorders, they tend to still be active and problematic. Even when things get better, I think we've not done a very good job of realizing that the tiger doesn't always completely eliminate the stripes. They could fade, but they can still come back under times of illness or stress, under times of academic challenge, or if young adults or kids make some bad life choices, such with alcohol or drugs. And even in my experience, for young adults, when the recession hit, that things could get worse because they may have been last in and first out in their job, or they may have never really established their career. The sixth point is important for the doctor, even more than the family, but the neurologist isn't responsible for everything. He's responsible for the neurologic component of the plan, And we need to coordinate that with other specialties and other pediatric generalists. The seventh, and now we're moving toward transfer, is that we need, along with you the youth, you the caregiver, parent, to find adult providers in the community where appropriate long before the anticipated time. And we are responsible for development of a transfer packet so that it goes smoothly. And the suggested time frame is not 6 weeks, but at least 1 year, and preferably even 2, in order to find people in your insurance plan, people who sound good on paper, but they may be so busy that their practice is closed or they don't take certain insurances. So we really need to put these in place. This is not so easy, okay? It's been shown that adult neurologists, at least in Canada, find it very difficult. 83%, 6 out of 7 adult neurologists say that patients with Tourette syndrome are difficult or impossible to incorporate in their practice. And if one looks at just the comfort level in treating these patients, even if they do accept them, only 60% are even somewhat comfortable. And 40% are either uncomfortable or would say it's impossible. And why is that? Because it's not just Canada. It's Philadelphia and New Jersey as well. Adult neurologists almost never feel comfortable with any of the neuropsychiatric disorders. They don't treat autism, they don't treat ADD, they don't treat OCD. They don't like mood, and they don't like aggression. And even my colleagues in adult movement disorders who do treat Tourette syndrome, who are ready to put in deep brain stimulation, they treat the tics, but they don't treat the comorbidities. And that's a different model of care that people just need to accept is the way life is. It's not just true of neuropsychiatric disorders, it's true of epilepsy, it's true of all of the adult disorders with very, very few exceptions. And the other point is, if you had a new patient who was disruptive in the office, who had severe behavioral challenges, who had inadequate insurance, it's not going to be easy. And the very last point is that the child neurology team, and that could be the social worker, it could be the nurse, it could be a care coordinator, ensures that not only do we have some place to help the child, young adult now, to move on, but that they actually have the appointment, make the appointment, and follow through. And this is all documented. And as I said, you know, I just did that again, I'm sorry. And as I said, my favorite philosopher, Yogi Berra, said, it ain't over till it's over, because we've had too many times where we've actually made the appointment with the kid and the appointment was never satisfied. So we don't want the bounce backs. So how does this work in the real world? And I know you can't see it, but I love this 12-year-old in my office one day who was wearing a t-shirt that says, "You never forget your first doctor." But then, and this is a different patient, graduating from college and having to say goodbye after many years of a close relationship. So let's take a kid, a boy with Tourette syndrome. Not surprisingly, he has some ADHD, some OCD, some sleep problems. He's a bright boy. He's an AB student. He has an IEP, mostly for the gifted intellectual abilities he has, but also for the opportunity for him to have time to take tests in a quiet space or extra time when his tics are bad. He's active in many ways. He's on medical treatment with Intuniv or extended release guanfacine and an SSRI, fluoxetine. And to help him to achieve sleep and also to recognize the delayed melatonin release of teenagers, he's on a melatonin pill a half an hour before lights out. His tics aren't so bad, and never or almost never do they interfere with his daily life. And so I think that's the time when we would begin to talk about the fact that he will be moving on at some point and that he should start thinking about who's responsible for taking his medicine and does he even know the name of the pills that he's on and what to expect if he is getting enough or not too much or not enough or too much. Fast forward a couple of years, and in a routine visit, mom says that suddenly he's not happy taking his medicine, and they're having occasional fights about it. She thinks he's taking it, but she has to push him and remind him all the time. He's still doing well at school, but he's having some more tics. At home, he's withdrawn and he is irritable. When you talk to him, he says, "My problem is I'm different and I don't like being different from the other kids, and I don't like how I feel taking the medicine. If I probe it, he doesn't really have any way to tell me why he doesn't like the medicine. It's not that it's giving him problems, it's more the idea. And for that, I'm happy to sit there and argue with him in order to help to define what the goals of treatment are and try to encourage him that these are his medicines and his life, and he needs to start increasingly taking charge. Because of the increasing tics and because of the irritability and the fact that he's put on 40 pounds in the last year and grew 6 inches, we increased the medication, not because he's worse, but because he still needs it, and at least discuss the possibility that counseling would help him to address issues that he's facing. A couple of years later, those A's and B's are not there anymore. At home, he's fighting, and he is slamming the doors. He admits that he's smoking on a daily basis, and even experimenting with marijuana because it helps him to relax and reduces his tics. So he says, what can we do? We're not psychiatrists or psychologists, but what we can do is use some motivational counseling try to help him to realize what his goals are. What do you really want to do in the next few years? I want to drive. I want to be on the basketball team. And I want to go to the best college I can. And then we can help to talk to the boy about how working with us and using appropriate medicine can help him to achieve those goals. And the other thing that we can do, if it hasn't already been done, is to refer him for not counseling in the usual sense, but cognitive behavior therapy, either for the tics or for the anxiety that seems to be cropping up. And when one feels in charge of one's life, it actually may help, and it's been shown that medication need is actually less. By 18, he's getting ready for college, and the tics are just escalating, and the sleeplessness is escalating as he's worrying about how this is all going to play out. We can help with that, but we also want to remember that it's almost time for him to think about whether or not he's going to stay with the pediatric model or move on to the adult model during the college years. And the pediatricians more and more are using a cutoff of 18 or college for their transition. And we would like to be in sync with them if we can. We're lucky that we have a social worker, but it doesn't have to be. Somebody can help them to find out how to negotiate at college so that they get the appropriate support. Every college has places where you can get academic support and psychological support. I always have a meeting with the kid before they leave for college to discuss what I call the rewards and the risks of independence, that unless they're planning on taking parents with them and hide them under their bed, they're the ones who are going to have to make sure when to go to sleep, when to wake up, when to take their medicine. And unlike high school, where all of the special needs supports come after the kid and make sure in high school that they get the IEP provisions, while everything is there in college, it's up to the individual to ask for it. And so advocating for oneself becomes a necessity as well as a goal. We try to give them a medical summary so that they know what their problems are and what they do in case of emergencies. And everything works all right, but now he's about to graduate college, and we've kept him in our practice. We've seen him twice a year, but now it's time finally to cut the umbilical cord. And we look around, and in fact, we just don't have neurologists who treat tics, ADHD, and OCD. That becomes in the field of psychiatry. So we make the summary, we make sure that we have included all the pertinent information, and we complete the transfer. This is all ideal. It doesn't always happen, not even in my practice where I'm really trying. But why are you listening to me and saying, this sounds like fairy tale? It isn't, and it doesn't have to be, and we're all learning. But in fact, we never learned about transition, either in medical school or in our postgraduate training. We don't find it easy as neurologists when we ask a question and don't know what to do with the answer. We may not even be comfortable, even at home, but especially in the office, talking about sex, drugs, and alcohol. And sometimes neurologists will say that these aspects are really the school's problem, and we hear that from parents too. And the answer is the medical aspects are not the school's problem. The educational aspects are. And while the overall transition plan really is best organized by the pediatrician, many pediatricians defer this talk to the specialist who understands the ins and outs of the problem. All that said and done, in many places, especially in private practice with small groups, but even in academic practice, there aren't enough people on the team with expertise. It's only in the last few years that the very large CHOP group has its own social worker. And one of the issues I hate even mentioning, but it's true, the time and the expertise it takes is rarely reimbursable. That's being worked on, but that's another story. So what can you do as parents and caregivers to help prepare? I just was in the office today with an older kid. True, he had what used to be called Asperger's syndrome, but the father never let him have a word in edgewise. I had to ask politely to allow the boy to speak for himself. They need to participate in refilling the prescriptions and making appointments, learning how to be in charge. The parents can help to prepare by networking, to find resources that have worked for other families, and where necessary to find appropriate funding, such as autism waivers and other things which may not be appropriate, but there may be need for special services. What can parents do beyond the medical aspects? Certainly helping a young teenager to become responsible can be helped by giving them responsibility, making sure that they have chores or jobs or even volunteer work. Parents can also participate in school evaluations and IEPs to make sure that the other life experiences are being addressed that will help them to be fully mature. That if there's no transition plan in a kid who has any special needs, that it needs to be articulated by age 14. If they do have an IEP, trying early to choose an academic track toward college or a vocational track where they're entitled to stay in school until 21 is important. And what parents need to remember is even if they're entitled to stay in school, they need to decide whether or not they will take advantage of that, because many kids want to graduate with their peers and leave at that time, even if they're not fully ready. Again, this is not most of our kids with Tourette's or even complicated Tourette's. Let me end by asking a few questions that might help you in making sure that you're doing the best. Do you see your neurologist or psychiatrist, who's ever in charge, on a regular basis? Do I feel that I have a partner in my doctor? Or is this just somebody who writes scripts? When I have an appointment, am I prepared? Do I have a list of questions, concerns, and do I give the doctor whatever information I think he needs in order to make good decisions? That could be report cards. It could be IEPs. It could be reports from the psychologist. But it's even better with the busy people to make sure that there is some transfer of information so that everybody's on the same page. At any age, does my neurologist talk directly to my child, especially to my teenager? Or is the teenager sitting there watching a ping pong match quietly? One thing that we are trying to do more and more is give the teenager the opportunity to talk by themselves. They may not have much to say, but at least they get used to the idea of speaking up without the parents in there. And am I taking advantage of everything that other people have learned by their experiences and networking, whether it's on the web or preferably with the New Jersey Tourette Syndrome Center? So, in summary, transition is really gratifying when it works. Scott gave me this permission to show this from his mom. Thank you so much. I know you've always been proud of Scott. Last year he was in marching band. He went to Israel. He's taking pre-med. He plays his guitar. He sings at the hospital. And he is launched. Closer to home in New Jersey, we have Tim, who started out and had many challenges, but found his creative side. Perhaps he went through his Jesus phase, but he wound up graduating and doing film, and he's launched. It's not always like that, but hopefully, as impossible as it seems, they all deserve to be adults and to graduate. And with that, I'll stop and I'll take questions. Thank you very much.
Wow, well, thank you very much. I hope you can hear me okay. So there's a lot of information to absorb there, but I guess one of the first questions that pops up is, based on everything you've said, would it not make sense for a child to be seeing a psychiatrist rather than a neurologist so that some of these things might transition easier or more easily?
For some children, that does make ideal sense. Unfortunately, accessing psychiatry with the challenges we have in our health system is more of a wish than a reality. Neurology is much more accessible, and I think that it's true that many adults have emotional needs that are not going to be met by anybody but a psychiatrist. But this is a neurologically based disorder, and neurologists are used to dealing with ADHD. They are used to dealing with behavior disorders, and they are used to dealing with intellectual disabilities. So we are the go-to people. I do believe that there are times where only a psychiatrist can help if there are major mood issues and other problems such as suicidal ideation, but neurologists are perfectly good most of the time, and I'm proud to take care of these kids.
Okay, thank you. Teenagers already think that the parents really don't know very much about them and what it's like to be in the situation that they're in. So by having a 14 or a 15-year-old begin to give his opinion on everything and feel like he can say no to things, doesn't that just feed that whole theory that the parent does not know best?
I think part of the goal of growing up is, in fact, to emerge fully independent. One walks before they run, but it is necessary to negotiate that fine line. That's why we have concepts like in New Jersey and in Pennsylvania, you can't drive certain times. You're not fully independent when you first get your license, but you really will never become an experienced driver unless you get behind the wheel.
Yeah, okay. So you need practice at doing these things. So baby steps, I guess, is really what you're saying. Yeah.
Baby steps. But it's
Yeah.
also the recognition that part of the job of adolescence is to individuate from the family and to figure out who you are yourself, and to start taking charge of one's life. As I said, the moment from high school to college, if that isn't done, is a total disaster, because who's going to manage all the things that mom and dad managed all those years?
Mm-hmm. Well, I've always felt that you get your kids to a certain age and you tell them everything they have to do, when they go to bed, what they eat, all those things, and then there's this magic age of 14, maybe 13, where all of a sudden a parent has no right to ask anything, and I think that that's a really unfortunate situation, and kids push that.
Part of the job of kids is to push limits, and part of the job of parents is to keep them safe. And
yes.
I'm not one who's going to tell you how to negotiate that eye of the needle.
Yeah. All right, so I have a question about a young man who is 19, and he has pretty complex OCD issues. And he has been to the ER twice now for anxiety and has been referred to a neurologist. So the question here is, what questions should I ask to make sure that I've got the right neurologist? And given everything you've said, in this case with OCD, would it make sense for a psychiatrist in this situation? So could you talk a little bit to that point?
If somehow one got to 19 years of age, you're going to be seeing an adult neurologist. Most child neurologists will follow their patients through college, but will not see new patients after 18. Certainly we don't. Okay?
Okay, yep.
So if you follow what I said before, it is extremely unlikely that you're going to find an accommodating neurologist in the community. They tend to be taking mostly care of stroke and Alzheimer's and Parkinson's disease. They're not going to be taking care of young people with neuropsychiatric disorders. If there are people in the community like that who are interested, I apologize to them. I haven't met them. We do have wonderful movement disorder specialists who take care of the tics, but they also refer their young adults with OCD to psychiatry.
Okay, so you think in this particular case, and as I understand it, this individual has had any number of prescriptions on SSRIs that didn't seem to, make any difference. So are you suggesting here that an adult psychiatrist might be the best approach here?
Especially if this is a medically difficult refractory OCD patient who's already an adult. They need somebody who specializes in OCD and is knowledgeable and expert in psychopharmacology. Not every psychiatrist can do that.
Okay, so this parent's going to have to do some research on this then, that's for sure.
Absolutely.
Yeah. Okay, I have a question about a 14-year-old who's doing well in school, hasn't had any serious tics in a while. So at what point would you consider stopping medication for someone like that?
Great question. I think that we all recognize that the medical treatment of Tourette's is like Tylenol for your headache, and it's not penicillin for your strep. So it's always symptom relief. That said, sometimes people will say, if it ain't broke, why fix it? I think that there are reasons why one should consider giving the opportunity to see whether or not an individual has, especially a growing individual, has outgrown the need for that extra support that medication provides. However, it's very important to pick and choose one's time so that if we're wrong, because we don't know in advance how important that medicine is, that if we're wrong, we're not going to create a crisis. In other words, I wouldn't do it, as I've seen happen, the day before people leave for vacation, or while there's illness in the family, or the week before school starts.
Mm-hmm.
I mean, times when there are going to be challenges is probably not the time. One needs to pick and choose and to be sure that they're prepared that it may not work out. Then having plan B to try to recoup that. The other thing that I would say is that nobody, even if it's theoretically safe, should abruptly stop medication that they've been on for a long time, because there are sometimes rebound effects that you would think prove how important the medicine was, and really it's because you got rid of the medicine too fast or in the wrong way. So you need to work with somebody. You don't want to have the kid experiment quietly and not tell you that he's not taking it. I've seen that. I hate that, where he just told the parents that he's taking the medicine, but really he was putting it away.
Mm-hmm.
Took it, and then told the parents a week later that he's off. Even if it works out, it's the wrong decision, and it's an indication of the immaturity or the lack of communication with the doctor.
Okay, good point on that. Yeah, you really should know if your kid's medication is active in their system.
Right,
In case there's a problem.
anybody who tells me that they didn't realize it, but on the other hand, the 1 month prescription lasted 3 months.
Yeah, I think that's a telltale right there, huh?
It's a telltale sign.
Yeah. All right, I think we've run a little long. I have one more question, though, and this one is specifically about this transition thing that you talked about. So it would be prudent, I would think, for parents to ask a doctor about their transition policy when they're,
Yes.
when they're getting, not engaged, engaged is the wrong word, but when they're considering to become, selecting a practitioner. All right, let me say it that way.
Correct.
So,
Correct. I think more and more you're going to be seeing transition policies posted.
uh-huh,
I think that we need to recognize human nature. And what you're asking is a great point. On the other hand, I know from when I bring it up, the parents say, oh my God, I was afraid you were going to bring it up. I knew it had to happen one day, but I didn't want to have this discussion. So, I mean, let's face it, the parents hopefully like their doctor and don't want to feel like they're being put out to pasture. But on the other hand, it is important, as one mother said to me just the other day, I know it has to happen. It doesn't mean I have to like it. It's time. And if you can start to do that, that is wonderful, and you can help to change the culture of medical transition, because whether the doctor wants to talk about it or not, whether you want to move on or not, your kid is growing up, and we want them to be the fully functioning adult that we know that they're capable of. And with that, I think we should say goodnight.
well, I agree. Doctor, thank you very much. I'm going to now turn this over to Kelly for a wrap-up.
Thank you all for joining us on our part 2 of medical transitions. A reminder to fill out your exit survey that we want from all of you. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that weren't covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our site. Our next presentation, Raising Emotionally Intelligent Teenagers, presented by Dr. Stephen Tobias, is scheduled for December 2nd, 2015. This ends tonight's webinar. Thank you, Dr. Brown, for your presentation, and thank you, everyone, for attending. Good night.